first of all, thank you very, very much, one and all. Like, thanks for taking the time to join us. I know there have been a lot of webinars. We've been having a glut of these, but thanks for taking the time. Hopefully, this is, I mean, we have a really stellar group of speakers and panelists. So I'm hoping we can all, I mean, I'm looking forward to hearing these legends talk and for the discussions. So, let me kind of get the ball rolling. I mean, I'll keep the introductions brief since most of them sitting here need no introduction really. But just to be polite, I'll just kind of give a very, very brief intro. So Dr. Ashir Ranga, who'll be the first speaker, again, is a really good friend of mine. All I'm going to say is he's one of the most prolific interventional cardiologists anywhere in the world, does a lot of complex PCI. You name it, he has probably done it. And, I'm very glad that he'll be kind of giving the inaugural talk. Of course, and he is from Malaysia, Sadang. And Dr. Kirti Punamaya, again, needs no introduction to a predominantly Indian crowd and globally, really. A master, left main, you name it, again, imaging guru, really. And I'm super glad that he's going to be giving us the talk on left main bifurcations. I mean, he's an authority in his own right, can go toe-to-toe with anyone in the world, really, on pretty much any complex PCI topic. And last but not the least, to kind of finish it off, you have Dr. Ziad Ali, who did his training initially in the UK and now is part of the CRF. I'm pretty much there in every international meeting. An imaging expert. He's going to give us his insights today. And right now, I mean, he is at Columbia, and he also, does a lot of complex PCI. So he's going to be talking to us about OCT and bifurcation. So he just did tell me that he'll be joining a little bit later, so I don't want to hold up on account of that. And then panelists, I'm just going to skip mine because hopefully people know me and I'm there. Dr. Atul, I'm going to start with that. Dr. Atul Abhyankar, good friend. We met last year, about a year ago, in another part of the world. Again, he is a fantastic operator, one of the most experienced operators in the country, has done more than 10,000 coronary interventions. He's at Mahavir Heart Institute, Surat, and he's the clinical director there. Again, very, very experienced operator. And, he serves as course director for a lot of international and national conferences. Then we have Dr. Deepak Davidson, who is from Kerala, again, has a stellar academic record, and once again, specializes not just in bifurcations, imaging, but also does a lot of complex angioplasties, including CTOs, and is kind of, just as a interesting tidbit, has the first to do multivessel angioplasty in Kerala through radial artery, first use the tornus. Then we have none other than Dr. Imad Shivan, who should be joining very, very shortly. Again, I'm truly flattered and honored that he accepted to be part of the panel. He's done more than 12,000 PCIs. Once again, has done a lot of atherectomies, imaging, PTCA, bifurcations, CTOs, name it, done it. Done more than 80 TAVIs, 200 PFOs, and a lot of left atrial appendage closures also. So again, needs no introduction to the, especially to the Indian audience, but truly honored to have him here. He also is a course co-director of C3. We still have Dr. Raj and Dr. Sengutuvelu. Again, Dr. Rajnikant is kind of the person that probably is the most prolific operator in Brunei, trained in a variety of countries, and does a lot of complex PCI, regularly holds conferences in that part of the world, very, very active in putting together meetings, and a fantastic operator and a really, really good friend of mine. So I'll keep these introductions a little brief. Dr. Sengutuvelu, once again, super talented operator, who a lot of us know has been always at the cutting edge of interventional cardiology. Anytime in India, he trained in France, once again, and has done thousands of complex PCI. So without holding it up anymore, I would love to invite Dr. Ashir Ranga, dear friend, to talk about to pot or not to pot.
Okay, I will without further ado, I'll just start the lecture. To pot or not to pot.
Hi, everybody.
Hi. Okay, can you hear me? Okay. Okay, I come from a public hospital, Sedang Hospital, Malaysia. Just a brief introduction. And it's actually quite a task, talking with this very prominent group of speakers today. And I hope that I can meet your expectations. So I come from Sedang Hospital, which is a public hospital. We did about 6,000 angios last year with 3,500 PCIs. And this is the new cardiac block, which is coming up with another 6 cath labs. We have 3 cath labs currently. Hopefully by next 1 or 2 years, it'll be up, the 6 cath labs. And I would like to thank Dr. Chi Kim Hui of Malaysia and Dr. Viraj from Bangkok for helping me with some of the slides here. And the learning objective is why we need to kiss and pod and how to kiss and pod. Is something sounds so simple, but yet I realize, a half an hour's lecture might not do it much justice, but I'll try. So kissing balloon inflation after dilatation is very important. If you look here, the stent is across the main branch, and just the pre-dilatation of the stent struts, the side branch, you find a stent position opposite to the side branch or ostium. And then when you put in stent, this actually malapposition gets even worse. So you need to do a KBI or kissing balloon inflation to correct this. So what is the evidence? Why kissing balloon? So kissing balloon inflation is obligatory for a two-stent technique. For two-stent technique, you must do it. And one of the earliest evidence we got was with the Korean COBIS registry, where they had about 1,700 patients, and they had the two-stent strategy cohort of about almost 300 patients with various stenting techniques. And what they showed was even as soon as 6 months, if you do kissing balloon inflation, full kissing balloon, and if you don't, you can see the marked difference in MACE rates, okay? So you can see that it diverges after 6 months and it still goes on up to 3 years, and the MACE rates just go up with the two-stent strategy if you do not do kissing inflation, okay? So this is for two-stent strategy. How about single-stent strategy, or what we call provisional side branch stenting strategy? Okay, so this is one of the earliest studies, the Nordic Baltic bifurcation study. I think they looked at almost 500 patients, over 5 years. And they interestingly showed that if you have a single stent, at 6 months, there's no difference, whether you kiss or not, into the side branch. And this data is actually supported even up to 5 years, there's no difference. But when you look at it carefully, there is increased death, cardiac death, and overall mortality in the kissing cohort. So if you kiss in a single stent strategy, you might be asking for more trouble. So this is also quite clear, keep it simple. So how about KBI for jail or compromised side branches, which we see? Previously, we used to just, POBA them and things like that. But now we realize there's a disconnect between angiographic and functional significance. So although if you see it is angiographically very jailed and so on, unless there's ECG changes, chest pain, or flow compromise, we try not to intervene. Unless, the other thing is if you have a physiology wire or wiring, you can actually wire and see what's the FFR like. And out of significantly angiographically side branches, only 1/3 are physiologically positive. But getting FFR wire into these branches is another thing altogether. And what is very important also is you have to know your stance, okay? So DS designs and so on, how much overexpansion it allows, especially in the setting of left main bifurcation PCI. So the older stents, you cannot expand very much, but the new ones like Synergy, Onyx, Expedition, Sierra, the expansion limits are actually quite big. And you need at least, if you want to do left main PCI, never put anything below 3.5. And you have to know your expansion limits. And we are hoping that we get even newer stents like the Megatron stent and so on for larger expansions and so on. And just to show you what happens if you put a trio stent in the left main and you go with a 4.5 millimeter post-dilatation, your stent is just a wreck. So, if you do not have an IVUS, for example, you want to do left main PCI, never put a trio, at least a 3.5. And you can see what happens when you post-dilate with a 4.5 balloon. And this shows that imaging is the key, either IVUS or OCT. I think all of you are familiar with S.J. Park's, landmark research and so on, published almost 10 years ago, where you go for 5, 6, 7, 8, the MLA or CSC after stenting. And subsequently, the Excel trial showed that maybe you should go for bigger MLAs and so on. And for me, the bigger is the better. And 10 is something I always aim for in the left main and strive to get in left main, and at least 7 in LAD. So this is what you should do. And imaging is really the key. I'll show you in the cases later. So how do you do kissing balloon and port and how to do it? I can tell you the debate is still on, but I can tell you what we actually do. So the prerequisites to a good case is you start off with a port. I'll show you later. Side branch wiring. So usually we use a non-compliant balloon at high pressure for adequate duration to optimize your second stent in your side branch. Then you end up with the subsequent port. So these first two ports might differ a bit. I'll show you later the data why I say so. And it's very important for you to understand the mathematical model of your side branch and your proximal main branch sizes. There are multiple formulas there, Murray's law, Finet's, and the more bifurcation you have, it gets a bit more complicated. There's also, Mitsudo. So basically, the rule of thumb is the main branch, you have to actually have the sum of your side branches and 2/3 of the sum of side branches. So this is a simple table tabulating that. The reason I put it in a table is sometimes you just take it for granted, but I can tell you, if you're not careful, you can have disasters. For example, if you put 240 balloons and you kiss, and if your left main is smaller than 5 millimeters, then you might actually end up with a perforation or rupture. So this roughly you should know in your brain, the calculation. So sometimes even if I have 240 side branches, I might, when the kissing, I might undersize it. When I optimize, I will actually use the appropriate balloon. But when I kiss, maybe I'll undersize the 4 to 3.5 and so on. And then, so imaging is actually key when you do these type of cases. So coming back to the concept of the plug at the side branch, and if you look at it, if you put a stent as size to your proximal segment, you find that one, there'll be marked plug shift. Number two, you'll have a choroidal shift which closes off your side branch. Number three, if you're unlucky, you can even have a perforation. So the compromise is actually sizing your stent always your distal segment size after the side branch. And then, of course, you have malopposition. So how you deal with the malopposition is basically doing a proximal optimization technique port. Okay, and then following port is good opposition of the stent and so on. So this is an easy way of putting it. So this is a paper just published last month in Sky, where you can see the cartoon here. What's very important is you must know where is the metal carina situated. So obviously, if your port extends into that, so you crush the metal carina, you can see here the side branch after port across the side branch, you will actually compromise the side branch. And if you port much earlier, you will actually keep the side branch preserved. So balloon positioning for port is paramount and is very important. So you have to know where the actual balloon, the parallelism usually is at the inner edge of the markers. Okay, it's not at the outer edge. And different balloons might have different properties. Be quite aware, and we try to aim usually for the balloon to be placed just at the carina level. And to do this sometimes is not easy. You need to magnify, you might need to use stent boost, whatever you have. And then you might even need to take multiple shots. The first spot is very important, but I'll show you later. It also depends where your carina, the metal carina is situated for the second port. So you don't want to compromise that. And this is one example. This is 3.5 millimeter cipher. And you can see, a 4 balloon where you place it. Sometimes it's easier said than done. You have rocking, you have a lot of other issues. This in the left main, it can be of paramount importance, especially if there's a size mismatch. You don't want your 4.5 or 5 balloon to jump into your LED. So sometimes you might need to compromise a bit. And this is again looking at final port where you have a simple side branch and you opened up and you can see the malposition opposite in the main branch stent. And then you do kissing balloon inflation. This is the other thing I'm going to point out later. There's elliptical deformation of the stent proximal stent segment. And so the potential benefit of port is it reduces strut malposition. especially the main vessel proximal to the bifurcation. So this will reduce the risk of inadvertent abdominal rewiring of the main vessel stent, open the stent cells, they can orientate the strut so they can wire the side branch better and facilitate rewiring. And actually, finally, it will optimize the final stent geometry, which is distorted by your kissing balloon. So this hopefully will improve flow dynamics and prevent thrombus formation. And the other thing I'd like to show is, sometimes we, when especially a single strand across, we'll say it doesn't matter if you try to go, proximal stent strut or distal stent strut. Why distal stent strut crossing is very important is because of this. If you have a distal stent strut, your metal carina is lessened and there's actually scaffolding. There's no gap, in your side branch ostium. If you have a proximal stent crossing, you'll find a long metal carina. So when you have a long metal carina, this will impact on port. So again, looking here, and you can see if you use a proximal stent crossing and you have adequate scaffolding, if you have a distal vessel crossing, you might not have adequate scaffolding. If you put a second stent, okay, you can see that. So I got it. So proximal stent, you can see there's a gap here. Distal wire crossing, you find that adequate scaffolding is there. Only difference is when you do DK crush, you go middle strut or proximal strut because the way the stent struts are oriented. Otherwise, always try to aim for the distal strut to cross. And these are OCT pictures looking at distal strut rewiring and proximal. You can see that here, the side branch is actually covered. Here, the side branch, there's a gap, you can see that. Again, looking at distal cell crossing, the post-kissing balloon, there's a nice opening here. In proximal cell crossing, you find that there are actually post struts across. And this is clot stenting, just to show you again. Sometimes you do not see it, but this is micro CT images and so on. So even in culotte, if you distal recross, you can see here nicely there's minimal metal carina. If you were to somehow inadvertently have a proximal recross, you'll have a long metal carina. So the issue will be when you pot it. And if you pot wrongly, if you pot across with this, you don't see the metal carina and you can actually jail your side branch with maybe higher mace events later and so on. So DK crush is the only technique where you go proximal or mid stent crossing, and you can see the micro CT images showing good. This diagram I got very interesting presentation, a publication by Andreas. It just came out in Sky Journal last month, where they looked at kissing balloon inflation strategies. They looked at port. So basically, they look at 3 techniques, and they have actually a phantom models. So if you can see here, this is your classical port ABI. So the thing is, where do you place your port balloon? So they found that if you place your port balloon across, this is a single stent, okay, across the main vessel, you find that in the rate here, your is compromised. And if you have proximal stent crossing, what you can see is you look at the yellow bar here, your metal carina is that long. You have a very long metal carina. And obviously, if you do port, you will going to jail some amount of the metal carina. And also, they looked at another strategy where you just port side inflate, you don't do kissing, and you report strategy. Again, if you cross proximal stent struts, you find a long metal carina. And the problem with ports, opposite stent struts in the main branch are malopose. So you still need to port across. Unlike if you do kissing, you can only. And I think Dr. Ashok Seth wrote a brilliant editorial in this journal regarding this. He also suggested maybe we can do like a mini kissing, something like what he mentioned last night, I suppose a snuggle or mini kissing, so that you just go and kiss into the area of polygon area of confluence. So you do not have to port because there's no elliptical deformation. The other thing here is what balloons do you use? So classically, here they're showing 2 large 4 balloons. This is a proximal single stent into a branch. This is a phantom model. And if you use semi-compliant balloons, you can actually, at high pressures, you can overexpand. Look here, 5.9 So you can overexpand. So that's the reason we use NC. And usually for kissing, we do not have to go high pressures. You're just trying to conform the geometry of the stents. And so during POT, you don't have to go high pressures. And how about the duration? There are papers stating that the longer you inflate the balloon, the better is the orifice of the side branch and so on. Obviously, you can't do this in your left main, but maybe for the arteries, you can consider at least more than at least 10 seconds to get your NC balloon up and port or side branch kissing. And this is again showing that single 20-second versus repeated second. A single 20-second you repeated, you actually decrease your acute metal recoil. So some people do multiple, but this is in the phantom models. Okay, again, whether you do, which you can do sequentially or whether you do simultaneously, the best if you get simultaneous inflation. The only time I'll do sequential inflation is, for example, I only got a 6 French guide and I'm doing DK crush. I can't get my big balloons in. You can consider sequential inflations, but you must ensure that your main branch is properly inflated, and long balloon overlaps. So try to use shorter balloons if possible. When you have long balloon overlaps, you can see here in A and B, the elliptical distortion proximal is actually longer. So this you need to really, pot this area. Some pot does not completely make your stent round. We hope it does, but it doesn't. So you can actually do minimal balloon overlap. Like this is what Dr. Ashok said was mentioning in his paper, I suppose, and where you can actually have just minimal balloon overlap. And if you really can control it, that it doesn't exceed into the main branch segment, approximately, you might even do away by not doing a pot. So this is important. And you can choose the eccentricity of the lumen. Look at A here is well-rounded when you have minimal balloon overlap, and look at B here, you have elliptical deformation of the stent, no matter how you pot it, especially large stents. And what's the worry about elliptical deformation is you can actually distort the stent geometry, and this can actually predispose to flow vortexes, thrombus formation. And with symmetrical stent expansion, you have homogeneous internal hyperplasia. With uneven asymmetry, you might even have stent struts which are exposed. And this can be needed for future stent thrombosis and so on. This is to show you the simpler version of sequence where in a single stent strategy, you can actually try to maybe avoid kissing, but I can tell you we still need more studies for this. But you must always ensure you do a final pot, whatever you do. So you can either pot kiss pot. Hopefully you pot kiss pot, because the first pot will make sure that you can wire your side branch appropriately. So whatever stenting strategies you use, whether it's T or DK crush and so on, you must make sure that you follow the proper techniques of simultaneous balloon inflation and also pot. And especially with TAP, I have to caution you, the metal carina can be quite long. So not all pot are the same. It depends where do you think the metal carina is ending, because you do not want to compromise the metal carina. And then what happens, you convert your TAP to a reverse crush and so on. So the take-home message, KBI, simultaneous balloon inflation corrects, kissing balloon inflation corrects stent geometry after stent balloon inflation across stent struts. KBI is mandatory after 2 stent technique. After provisional single stent is generally not encouraged unless the flow is compromised. The optimal port, you have to port before distal strut wiring. This port is very important to put the balloon in the proper position adjacent to the carina. Properly sized NC balloon should be used at adequate pressures. I think imaging is the key here. Avoid long balloon overlap. And the final mandatory port after KBI final port is mandatory after KBI, but be careful not to distort the metal carina. I would just like to present 2 quick cases. One is a DK crush. So this is a 69-year-old male who had comorbidities of diabetes, hypertension, dyslipidemia. This is a typical Malaysian patients at cervical PID. an angiogram done in 2004, which is normal. He was having chest pain. He went to a private center. The stress test was done, was positive. So the echo, the EF was preserved. So he had an angiogram. It showed the distal left main bifurcation, but he was not keen for CABG. So he actually presented to us with unstable angina. And this is the baseline angio. If you see this haziness in the distal left main, it's not so clear cut in this view. In the spider, you can appreciate there's something there. And here it looks like a borderline, but it's actually hazy. And what happened was we wanted actually to do an IVUS study. But what we found was we actually went radial, and we had difficulty actually putting the IVUS through into the circumflex. And initially the LAD also. So we actually pre-dilated the circumflex to 2O and balloon, and this is the pullback from the circumflex. So what we realized is the left main was almost 5O vessel. There's a tight proximal circ lesion. The vessel size proximally for the circ was 4O, and the distal left main was 5.3. So if you go by the guidelines, they say maybe you can use physiology here, but he already had a positive stress test, so we decided to intervene. And this is the pullback from the OM. The OM was a 3O vessel. And this is from the LAD. Interestingly, the LAD, there was a triosteal lesion. The MLA was just 3.26 there, which was not evident initially. And we wanted, and actually the landing zone is all the way to diagonal here, and beyond that there was a myocardial bridging. So with IVUS, you get all this information. So from IVUS, we know that the left main is 5O, the LAD is 4, then you need the 3O circumflex, and where to land, and so on. So what we did is we deployed the DS 3016, pulled back, went up higher pressure to flare, and at the same time, you must always make sure you have a balloon across for DK crush, and this is your first port. In DK crush, basically you have 3 ports. One, if it's not 1-to-1, you'll have trouble later. And then we rewired the circ after that, and then we pre-dilated balloon, and then we actually managed to put 2 balloons in from the IVUS. We knew that the circ was 4O, LAD is also 4O, so we put 4O 3.5 vessel. And mind you, the reason we didn't put 2 4O balloons is my left main is smaller than 5O. If you put 2 4O, you might, the 2/3 of the balloon dilatation will be almost 5.3. And so you get this into, sorry, let me, so this is the LAD stand. We put a 3.5/38, never put a 3O stand in the left main, minimum 3.5 and above possible. This after the LAD stenting. So we actually rewired the OM again, pre-dilated with a Rure to deliver the second balloon. So I put in an NC 3.5 in the circumflex, and you can see that now I'm pre-dilating, I'm optimizing, post-dilating the stand in the LAD with a 4O high pressure, and actually my 3.5 balloon is already there in the circumflex, if you can see, so that this makes life easier. So the second case was with the 4 LAD balloon and a circumflex 3.5 with just 12 atmosphere. So we popped to improve the left main strap apposition and so on with a 4.5 balloon. So this is the results after the second case and port. And the CSA was actually pretty good, 11.6, and CSA in LAD was 8.6. And the CSA in the circumflex Austin was 7.45, which is very good. But me being a bit, I'm a bit, so the stand I thought was a bit underexpanded. So I'm a bit obsessive compulsive, I guess. So I went back again to go with a 4 high pressure. So that meant that I had to do the whole kissing and everything again, and port again. So these are the final results, which I think is quite acceptable. And so that was DK crush. So imaging is this is the second case, culotte left main bifurcation PCI. This is shorter. We had a 57-year-old male with hypertension, Hep B, he had ischemic heart disease. He presented with actually event, and we did PCI to the RCA earlier, and we plan to stage PCI to left main bifurcation. You can here appreciate there's a tight distal left. Actually, the ostium circ is actually very tight. Here you can appreciate the ostium circ here. I think I have a video. Yeah, you can actually see how tight the ostium circ. In fact, we had a lot of difficulty just trying to wire the ostium circ. We use a radial approach, 7 French. Always try to use a 7 French guide at the least, because it will really be helpful. So we used the Gaia one wire finally crossed. We lifted a flap, I think, in the ostium of the circ, but in the end we managed to pre-dilate, and we did IVUS. And the IVUS showed us was a left main. It was again almost a 5/0 vessel, and the OM was 2.5, proximal circ 3.5. It also helped us it told us that there's not much of calcium there. I didn't need to rotablate, so maybe with a cutting balloon I can just escape. And this is a pullback from the LAD. And interestingly, the LAD, the aneurysmal segment just before the diagonal was 5.3 to 5.6. And the mid-LAD, there was no disease. So I just had to go before the aneurysmal segment, and the vessel was about 4.0. And if you look at the tightest segment, was 4.5. So 4.5 is in the, if I'm not mistaken, it's in the ostial of the LAD. So here, we decided to go with a Collard technique because I want to secure the circumflex first. So I know that the left main is 5.0, LAD 4.0, and the circumflex 3.5, but it's very short. So we got in DES 3.513, and this is after the DES, we removed the LAD wire, and we actually went up high pressure, opened up the stent struts, then rewired the LAD through the distal stent struts. Then we put in a 4.018 stent, pull back, flat at 20 atmosphere. So we managed to rewire back the circumflex, and we did kissing at 4.3.5. Remember that you're very careful of going 4.0 if your left main is less than 5. So we did a port with a 4.510, and this is the final results. And I think I have IVUS results here. So the CSA was much better now. So anything more than 8 in the left main, you're happy. This is 15, and the circumflex was 12. The stem was well opposed. So this is the final results. So proper technique and imaging, I think, is the key to success. Thank you. This is my new building. Hopefully it'll be ready by next year or end of next year. Thank you.
Ashri, that was a fantastic talk. And I mean, gosh, we have like so many experts here. I'm going to have my pick of people. So, Dr. Imad, like, do you want to kind of, comment about the 2 cases? Anything that you have to say, or any words of wisdom?
Well, actually, I mean, both cases are well done with 2 different techniques. I think that the discussion should be when you need to do 2 stents in distal left main, because at least one of these cases was having only focal lesion on circ. So I think in that case, the alternative could be also provisional stenting. And just if you have good result on circ, that means with no residual stenosis, significant residual stenosis, even measured by FFR, I think it could be good enough as well. I mean, without putting another stent, without complicating too much the procedure. But anyway, this was a very educational case, I think, for kissing, for culotte, and for DK crush.
Thank you very much for that. And so, guys, like, we have a couple of questions that popped up. So I'm going to request Dr. Rajnikant to kind of take the first question. I think both are good questions, and it would be good to get the perspective of the various panelists. So, I mean, India, as a lot of you guys know, we try to minimize the hardware yet give optimal results. So when you do have, like, can you use the 2 balloons that you use for kissing, just come back and kind of do a proximal repart? Like, what's your take, Raj?
Thanks, Ron. I think we go back to what Ashri's point, the point Ashri made about elliptical deformation. So 2 balloons dilated in the main vessel will not get the same effect as a pot with a bigger balloon, because the way the balloons expand will be like 2 cylinders, obviously, and they expand, and there will be a gap in between where the stent deformation may not be corrected. The reason for doing a port is to correct the stent deformation that we get when we do a side branch dilatation, when you do a kissing balloon. So if you pull those two balloons back, you will expand the vessel, but I believe that you will not get a correction of the stent deformation. Therefore, and if you have an elliptical deformation with two balloons, even if you pull back the same two balloons into the proximal vessel and dilate them, you will be left with the elliptical deformation. So unfortunately, it calls for a dedicated balloon. That's what I would do. And there is more to it. I mean, Ashri made it very clear that there is no clear evidence for using kissing balloon dilatation after a single provisional stent. It is not just a stent deformation, there's a lot of things that can get affected when you do a kissing balloon inflation. We look at the metal, but there is also polymer. You lose polymer integrity when you are dilating a stent and leading to distortion of the struts. The drug distribution can be affected. Different stents have the drug distribution in different parts in different designs, and that can be affected. And there is intimal injury. So when you're putting in two balloons for a kissing balloon inflation, you dilate them in the main vessel, it can lead to more expansion in certain areas, leading to intimal injury. So even if you do a pot and correct the metal distortion, the intimal injury is already there, and this can lead on to long-term ISR because of inflammation. So these are things to think about. I think there should be a really good reason to do kissing balloon inflation. And yes, and I would certainly recommend using a proper pot than pulling back two balloons. I don't think it serves a purpose. I don't know if others agree.
Any dissenting views? So let's take, in the interest of time, I'm just going to go on to the next question, which is so I think you guys can all see it. So when will you do a pot side pot, and when a pot kiss pot for left main bifurcation? I think we have kind of touched upon it. So anything else to add at all about that? Or I think Raj kind of covered both.
Yeah, I think go ahead, Raj. Dr. Kirti answer.
No, I think Imad was going to say something. I think they have a view. And Imad, you want to say something?
I think that there is a complete agreement today. If you do not have any damage on side branch, any compromise on side branch, you do not have to do any side branch crossing or inflation. Just do pot and finish there. If you have some damage, some compromise, then side branch inflation, that means mostly is due to plaque shifting. Undersize your balloon, you are going to side branch in order to avoid dissection side branch. And then it's enough to repot after side branch, that is, without kissing. Every time you are doing kissing, then I think you should go for pot anyway. But if you have done already pot, enough pot, proper pot, and you are crossing side to side branch with smaller balloon, then you do not need to repot, because side branch with smaller balloon will not give any deformation on the stent. So these are good points to remember when you are doing provisional stenting.
Thank you very much for sharing your perspective, Dr. Imad. Dr. Atul, please go ahead.
Yeah, I just happened to be with somebody doing a case, and that's why it came to me that this must be added. That when you are doing this left main kissing, long time, 1 minute kissing, etc., you have to keep in mind the clinical setting. I have recently seen a patient being lost because of an acute coronary syndrome being treated with left main bifurcation kissing, and during kissing the patient just crashed. So when with all the strategy of longer balloon inflations is okay, then you're doing a totally elective case, but you have to be very careful when you are doing an unstable patient, and longer balloon inflations, even during kissing, is definitely something that is not advisable. I also wanted to tell you something very interesting that we saw just 3 days ago. And When I used to do a LED to left main, and if circumflex had no disease on imaging and circumflex didn't get affected while putting a stent across, and we did a port and we had absolutely nothing of concern with the circumflex, I used to think that probably the strategy of not even wiring the circumflex is a good strategy. Recently, I did a case where in imaging, we found that a case done 3 years ago, we actually found that the circumflex got stenosed with 2 lumen. And there was actually a growth on the struts that were hanging across the circumflex ostium. So I have some beautiful images of that, as maybe in some meeting I can show that. But we actually found that the circumflex developed 2 different lumen and both were quite narrow. So after seeing this, probably I think that doing a balloon, even when you don't damage, I mean, you haven't got pinching of circ or narrowing of circ, even then probably just taking the struts out of the way in the circumflex, probably my view has changed after seeing this, that probably it might be a good strategy.
Dr. Atul, coming back to your first comment, when you say prolonged balloon inflation, never in the left main, because you are using large balloons to inflate, and don't forget the deflation also takes time. So you're talking about epicardial arteries, then fine, but if long left main, up and down, you have to be rather quick. Not too quick, but not too slow, because the deflation also will take time. Yeah.
Good point, Ashri. So, Dr. Deepak, could you take the last question? I mean, it's an OCT question. One of the things is like, how do you ensure distal wire crossing? And I mean, like, what do you do? Do you take the wire out, recross it if it's not distal enough? How many times do you do OCT?
Yeah, that's something.
Nishit has asked Dr. Chandra has asked a question.
Yeah, that's something very, very interesting and very close to my heart. But prior to that, let me congratulate Dr. Asri. It was a wonderful talk. It was a very lucid presentation. And what I enjoyed most, the point that I liked most was doing a bifurcation even through the radial, use a 7 French guide catheter. Because nowadays we all try to be radial fanatics and try to use 6 French guide catheters. 8 out of 10 you might be able to get away with 6 French guide catheters, but 2 out of 10 you might encounter challenges. So if at all the radial artery is very small, I would definitely prefer going through the femoral approach with the 7 French guide catheter. That is a wonderful, wonderful message. One important point that I just wanted to clarify was every time you want to do a pot, repot, every time the balloon distal marker is almost always at the carina, but just one scenario wherein you would want to have the balloon away from the carina is when you do a tap and when you do a repot. When you do a tap, you always have a strut protruding into the left main bifurcation almost near the confluence. So at that point of time, when you do a repot, get the balloon away from the carina so that you don't crush the stent strut that is protruding into the main vessel. That is one point that I wanted to highlight. And then regarding this OCT and distal recrossing, nowadays with the advent of OCT, we always try to do, and every time we do a left main bifurcation staining, we always try to do a OCT pullback from the main vessel after crossing into the side branch and try to see whether we have gone distally or whether we have gone proximally. And many times we try to avoid doing a culotte staining. We always try to do DK crush. So in almost all these situations, we try to see whether the wire has gone proximally in the first cross, and we try to see whether the wire has gone in the distal cell during the second cross. So it's always 2 extra OCT runs, but we try to reduce the contrast. You see, we try to make it to 10 ml contrast and get the pullback, a short pullback from the LED back into the left main so that the contrast usage could be reduced. And there have been situations wherein we found out that the wire has gone through a very remote cell. The balloon doesn't go in through that very remote cell, and we had to pull it back and get the wire into a distal position or a proximal position so that the wire crosses. I should also confess that there had been situations wherein we have made sure that the second cross has gone through the proximal cell. We try to recross through the distal cell, and the balloon hasn't gone distally through the distal cell. Again, we had to pull out the wire and gone through the proximal cell. These two also happen while doing DK crush technique. So, but still we always try to do the sort of see how exactly the wire has gone through, whether it has gone proximally in the first cross and whether it has gone through the distal cell in the second cross.
Well, actually not complete distal. Actually, even in DK crush, I think in the middle, you should try every time, because sometimes you can if you are trying to cross distally in crush and you do not have well-opposed stent on the ostium side branch, you can get out with your wire outside of the stent and re-entry in the side branch. And this can cause very, a big challenge to be corrected. I mean, you will crush the stent after inflation and will never be coming back. You cannot put another stent because you have already two stents there. So I think it is good to not to extremize distal crossing in decay crush, even in the second crossing.
Dr. Kirti, please.
I think amazing, Asri. That was a great talk. I have just a couple of practical things that I follow. I think the point that Atul made about growth on a link, which is across a branch, I think that becomes relevant when you start going into smaller arteries in the side branch. So the smaller the side branch, the more relevant that is going to be. But if you start seeing on imaging that your circumflex ostium has no disease, and if it's 3.5, that means you're also talking about 9.5. You're already talking about a 9.5 millimeter square area. A link or two across that makes no difference, in my opinion, and those do not hurt those patients. So you're particularly looking at circumflexes, which are either small, in which case you have a super dominant right coronary artery, and you know that already. But to have a 2.5 minimal luminal area with no plaque burden, that means you're talking about a circumflex artery, which is almost the relevance of a diagonal branch. Then I think, yes, you might take that one step to make sure that it doesn't occlude if that is going to be a little long distribution. I think the point is we should make it as simple as possible. And we should very, very early on decide whether this is going to be a single or a two stent strategy. And if you use a single stent strategy, then you should make sure that you are able to easily convert it into a two stent if required. I think that's the...
Kirti, I would have agreed with you 3 days back, 100%. But I will show you these images and maybe you will also change.
I know a single case won't change the rule though, but yes, I'd love to see it.
I've never seen anything like this in my life. I will show you those images later.
Of course.
Are you talking about neo-intimal bridges? Is that what you're talking about? The neo-intimal wall on the stent pads?
Yes.
Yeah.
I see them quite often when I do OCTs from my previous left main scans. And even with Absorb, with BVS, 3 years on, even as the scaffold disappears, you still have those neo-intimal bridges still staying around. I got a sort of a 5-year follow-up of a 3-year follow-up of an Absorb, sort of a case series. And it's interesting. Yeah, you're right. That made me question this. But I don't think I still think the flow is good despite the neo-intimal bridge.
That's right.
But this was a big 4-lane bridge.
Wow. Okay.
Wow. All right. Hey guys, I'm going to save some of the other questions for later, if that's okay. I'm just really looking forward to Kirti's talk. Ashri, again, thank you so much. By the way, guys, if you do realize the differences in time, Ziad has some personal issues that's ongoing right now, so he's still trying to make it. Ashri and Raj is like late in the night. These guys are super kind, and Kirti's been like, I mean, he was like, I'll be there right away. And so did Dr. Imad and Dr. Atul. So thank you guys. Really appreciate it. So Kirti, on to you. Can't wait to hear about left main bifurcations.
Arun, thank you for inviting me this evening. It's a pleasure to be on this absolutely august set of people. And I'm going to try to make this practical, and I'm going to just pick out of my basket cases and how I've approached it. And in that will fall in line probably some of the principles as they have been, as they are, and as have changed in my practice. So if you can see the screen, can you see the screen, all of you? Yeah?
Yeah, we see it.
Okay, great. So let's start with the first. So we take a 61-year-old who had chest tightness with with very limited exercise tolerance for last 20 days on a background of exertional symptoms for a year with an Agustin score of around 1274. These are his risk factors and those vitals over there, his risk score, his profile, with a normal renal function, and this is the angiography. So the angiography shows a tight distal left main. It's a trifurcation, almost like a pseudo trifurcation with an very early OM, which is less than 2 millimeters away from the ostium of the LAD, and a circumflex artery, which is, for me, is it a significant artery? Is that a large area? But all three significantly narrowed. Now, for me, how do I plan these left mains? If I do have a CT angio from before, it helps. But if I don't nowadays, in this in the left main segment at least, I do a CT calcium score or calcium map, and this calcium map helps me. In this particular case, the calcium map helped me in the fact that the left main, distal left main going into the LAD was an eccentric calcified area. The ramus was relatively spared of calcium, so I know that I'm not going to have to run my burrs and big ablative equipment into that artery. But my circumflex artery was clearly calcific, and if I had to get any resounding opening of that artery, then it would have to have some work being done on it. The second thing I do is I kind of make a cartoon in my head, and sometimes I draw this cartoon on my board in the cath lab, and my entire team then kind of sits down and they need to understand what are those areas which I need to kind of work on and what are those areas they need to help me, because in my lab, I'm a single operator person. I just have myself, my nurse, and my technician, and my anesthetist. So it's a very small quorum in the lab. In this particular case, our problems were, is the ongoing circumflex significant, or can I just make it a bifurcation stent and simple and get it out? So is there an origin of the OM or ramus significant, and would I have to even touch it? Do I need a rotational atherectomy? How do I plan it? Which would be the artery to go for it first? Would I then require one or two stents? I mean, two or three stents for this distal left main, and should I consider IVUS or OCT? That's always a question. So I think when the IVUS doesn't go, you pull out a rotablator, and this is a 1.5 rotablator going into the circumflex artery. So we wired the circumflex artery right down and spared the OM as we thought, and just put in a 1.5 burr. So what that does is it actually gives me some room, and the two black dots are those which mean that now I have set up myself to do a pullback IVUS run from the main circumflex artery back. And my areas of interest are as those lines marked. Believe you me, when you have an IVUS coming back from an angulated artery into the left main, you don't get the right images and the cross sections because you have an oblique image in those arteries because of your wire bias. So my second is going to be a pullback from the ramus, because that's where I'm going to have a slightly better understanding of my left main to start with. But I always confirm this with a pullback from the LAD as we go along, and that's important. So for me, the images that I marked with a red line are the important game-changing images for me, so to speak. So let's look at that. So these are those areas in the angiogram that you need to worry and focus about. And so this is 2.9 is the area, is the diameter of the distal landing zone in that ramus. 2.6, so this is more than a 2.5 millimeter artery. The lumen, which is 2.6 in the landing zone, the artery is clearly 2.9 or 3 millimeter long. So it looks narrowed because of the extensive plaque burden in it in the proximal segment. And obviously it's probably underfilled. Now, when you come on to the ostium of that, the origin of that ramus and the cross point, branch point of the circumflex artery, these images are important for me because these decide strategy. Now, the circumflex artery, you can see that there's a circular plaque which goes all around. The plaque burden is more than 70%, and so is the plaque burden more than 70% in the OM origin. And you can see that there is plaque almost certainly. There's a little bit of plaque even at the carinal. If I were to put a two-stent strategy and not put a stent in the circumflex, I'm very likely to close one of the circumflex artery, very likely. So these images prompt me that I have to be careful. I can't just not save that circumflex artery. And in these calcified lesions, this has to be a prospective decision. Provisional may become too difficult to handle when you're talking about complexities like this. So that's an important issue. When I come to the circumflex ostium, you can see that there is a very large plaque burden. You can see the LAD ostium is looking right over there because your cross actually goes into the LAD because you're obligated. Remember, these images are never reliable in terms of measurement because they do not have an absolute cross section. They have a beveled view of the circumflex ostium. We just don't have a technology that will give us a proper view. And I can say the same about OCT as well. When you look at, could I get away with a short stent in that ramus branch, right? Do I have to put a long stent or a short stent? Even though angiographically, it might think you could take a 8 mm stent or something, or 13, 12 mm stent for that artery. When you look at where that short stent would land, the MSA, the plaque burden is more than 55%, and the MSA is 3.8, which means you can only choose something like a 2 mm stent and then start, because otherwise you're going to undermine the plaque and dissect it. But if you were to extend it a little longer, you can get your whole 3 mm and you can have a better landing, a better diameter of that stent that you could use and then expand. And that's a very important feature. Now, once I've done that, and I've done everything to prepare the lesions in these two areas, I now take a pullback from the distal, from the LAD into the left main. And the far right image is the distal landing zone, which is 3.7. Coming to the ostium of the LAD is an MLA of 3 with eccentric sheets of calcium between 9 and 12 and between 2 and 4. You can see the circumflex wire at 6 o'clock. What is important is that the areas of calcium are far apart and they're opposing, which is good in a way, and I'm going to tell you why. And when you come into the distal left main, you can see that the sheets of calcium are between 7 and 12 and 3 and 7. This is relevant, and the lumen is good because what it tells me is that from the left main to, and if you look at where the position of the IVUS catheter in the distal left main is right in the center. It's important to note that, because in this patient, if I have to put in a burr and roll the burr from the left main into the LAD, it's not going to do anything at all. So it's a wasted effort to start with. For the rotoblader to work on this calcium, that wire should have a better bias towards one of the calcified segments. So once I know that on the image, I know there's no point in me using a rotoblader. For me, to get rid of that plaque, I need to use an IVL balloon, because there's opposing calcium. The IVL is going to work. You can increase the size with a flextrum in this case, and you can see that it cracks the calcium sheet. Perfect. So that's job done. Next is, how do I plan my stents? So for me, I have to look at the easiest way and make sure that I don't lose a branch. And that's important, because when you lose a branch, even if it is temporary, it increases mortality and it increases issues in the cath lab, and hemodynamics go haywire in the left main. So my first stent is going to be here. Then I am going to pot and then put in my second. So that's what I did. I put in my first stent in the circumflex, and then I took in a balloon through that and opened up the struts and did a pot. And my second stent is going to be here. That's a 3030. I've decided the stent on the IVUS, and that's the stent that goes in here like this. I open the ostium of the circumflex with a 3.25, 10 at 18 atmospheres, and then I do a pot in the LAD with a 4.5, 5 mm balloon at 15 atmospheres. And then it just sets me up for the last step, which is going to be my stent into the LAD, and I repeat the pot, I do the kissing, and all this later, I mean, we're done. Now our job is to find out what our result looks like. And so these are the areas of interest: the ostium of the ramus, the ostium of the circumflex, the ostium of the LAD, the confluence and the left main proximal edge are going to decide your long-term results. And here are the results. And you can see that this is well expanded. The only area is the circumflex ostium, looks a little under expanded to me. And so I went in back with a 3.25 balloon at a slightly higher pressure at this point, completed the job. And this is our long-term, this is our final angiography result. The IVUS I've already discussed. Going to the next case. Do we always, I mean, we see that there's a 111, it's a calcified lesion. This is an elderly lady, 84-year-old, who had the STEMI. She had a pacer rhythm, so it was difficult with pulmonary edema and calcified lesion, eccentric, ostial circle involved. Now, what's important, how do I do this? Do I use 2 stents for this as well? For me, it's a rotablator, so it's 1.5. And in this group, I would do a 1.75, which I do. And then I put an IVUS pullback. And the circumflex ostium is an extremely short lesion, less than 3 millimeters into the ostium, and it's soft. For me, this means I can avoid a stent, because even if I compromise that circumflex, it won't be difficult to cross it because it's soft. And if I have prepared that ostium well, then I should be able to cross it without any problems. So my stent technique is going to be here. Landing zone is 3.25 distally 4.0. You could take a 3.5. You could take a 4.0 at a low pressure. Either stent is a choice of the operator. I would take a 4.0 because the left main is 4.0. Put it at a shorter, at a very low atmosphere, expand it, and then do final expansions with the definitive destination balloon size. So we put in a flextome into the LAD, dilated the ostium of the LAD after the rotablator. We took a 3.0 flextome, just the mouth into the circumflex ostium, dilated that, and a single stent strategy. That's the result. 9 months later, she came for a pacemaker battery a change. That time we had the ability to change, and this is her long-term angiographic. This is a 9-month angiographic result. This lady is 4 years out, and she's doing well. So not all patients require 2 stents, and we should try and avoid those 2 stents. This is a 73-year-old unstable angina. You can see his history. You can see his vitals. This calcium score is even more. It's 3790 now. And this is the anatomy. His right coronary artery was significantly narrowed with heavily calcified lesions. We sorted that out as a stage 1, 3 days prior to, 7 days prior to this. We got him back for the left main. I think it's important to know that it's very difficult to even advance microcatheters in these arteries. So you have to be prepared to have all options on the table. This is his right coronary artery, which we kind of got out. For me, what is the plaque? The plaque looks like this. This is what I have. So my first challenge is going to be wiring. Remember, when you start making these cartoons on the wall and try to represent your angiographic thing onto your boardroom, then you are going to quickly realize that the biggest challenge is going to be wiring. Why is wiring important in this? Because if you start off on a wrong foot, you can easily close off this artery, and you could even have a disaster even before you start. And that's important to realize. So for me, wiring this artery and getting access into the circumflex artery is prime importance. The LAD ostium looks okay here on the angiogram. The OM ostium is important, and I need an IVUS assessment of that. And that's going to decide whether I need to use any bifurcation strategy, or it's going to be just stent from left main to circumflex. So here's my microcatheter struggling. You can see that, but very often you can just rotate it and then get in along. So we did that. And once that was done, we do a rotational atherectomy with a 1.5. This took around 5 minutes of rotational atherectomy time into the circumflex. And once we had that, we had the blue images, which talked about the landing zones in the respective areas that I've shown, in the left main, in the ramus, and in the OM, and in the circumflex. And what is important is the circumflex ostium, you can see, is significantly narrowed, and you can see that the OM ostium is significantly narrowed. And you can see that the OM landing zone, the reference vessel is around 3.4. The luminal diameter is around 2.7. So that OM is a 3.0 artery with a 3.0 stent. And it looks like it's going to require a stent. The question is, how are we going to do this? That's one. And the IVUS run from the OM to this is the IVUS run from the OM to the left main. And these are the 2 IVUS runs which are relevant at this point. So once we do that and we have this information, that's your IVUS run. You can see the circumflex ostium and its relationship to that distal circumflex. These are the IVUS images of the pullback from the circumflex back into the left main. And this is the pullback, and you can see the images as we go. What is interesting is if you look at image A, it's an eccentric plaque, the lumen is good, we can land a stent over there. If you come into B, it's where the origin of the OM is. You can see the origin of the OM. And interestingly, this IBIS image B shows that there are two opposing calcified nodules protruding into that circumflex. One is on the superior surface one, and the big heavy duty one is on the lower surface. And our rotablator has gone ahead and shaved off one of those plaques. You can see, and you can see that very well in the image C and D, which are marked with the arrow, because that's what the rotablator has done. It tells me that the rotablator is in proximity of that calcium nodule, and one should take this information seriously. And this means for me that 1.75 burr or a 2 burr in this place is going to make my life easy. So that's what I do. And very important, this is very important image information for me. The mid-circumlanding zone is around, the landing zone is around 3.6 millimeters in diameter, which is good. Post-rotablator, this image also tells me that I need to have a flexed-dome balloon 3.0 in the OM branch and 3.5 in the main circumflex for me to set up for any kind of stent deployment. Once I've done this, we go. This is our flexed-dome balloon dilating the circumflex and the OM. We've got this. Our first stent is going to be into the circumflex from the left main. This is a large stent, and then I do a pot, because then I stabilize it. Once I do a pot, I know that I'm not going to deform that left main stent. I then have a second stent going in, which is a smaller stent, helps me. So this is my first stent, and I always do this, put the proximal stent first. It's just the way I do it. I'm more comfortable this way. It makes my landing of the second stent much easier. And this is one, you can see these images, and I take my second stent, and once I've done that, what's important is to go into that artery, create a room, and then do a final kissing balloon with that. This is what we do. And then our images, and you can see our images show that our MSAs are very accepted. Look at the last image down there, the left image on the bottom row. You can see that even though the stent is expanded well, there is a malapposition. Don't try to correct that. You're going to see that in calcified nodules. You don't need to do any more than this, because you're going to deform the stent and then it loses its radial strength. So don't chase it beyond this. This is a good opening. You can leave it alone. In eccentric lesions, if you see in the left top column over there, it's an eccentric plaque. And whatever you do, you never can make that a round stent. It's never going to be a circular expansion. It's always going to be like a D. So don't try to chase it. In that chasing it anymore, you can rupture that artery. Remember that. That's as much as we can do with our current technologies in this game. So this is our final picture, and the patient's doing well. Let's go on to the next. And this was the RCA that we did a few days ago. Case 4. This is a 76-year-old unstable angina, restrictive lung disease. You can see everything. The calcium score on CT is 1200. For the LAD, this is the right coronary artery, and that's the left main. Now, she's a 80-year-old or 76-year-old lady, 90 kilos. She has no neck at all. So even putting a central axis is difficult. And this is an anatomy heavily calcified. So how do I assess it? The first thing is, I told you, these are the lesions. The left ventricular diastolic pressure is 18. And the CT scan calcium score shows that there's a huge block of calcium going from the left main, with its arms going into the circumflex and the diagonal branch. And these are going to be unforgiving arteries, really. So it's very important to plan it right. This is my image to start with. And I have a circumflex. I have deep-seated calcium. Based on it, my calcium tells me that my left main is not so calcified, except for the origin of the circumflex and the LAD. But there's a sheet of calcium in my LAD, as you saw in that CT scan, extending into that, partly into that branch there. And then it extends eccentrically down. But that diagonal branch looks pinched from the angiography, and that's my representation. These are my issues as I mentioned them. So the first thing I do is I get an impeller in place for this, because these patients can crash easily, and you don't have a game changer plan you have to have a secure plan to take these forward if you're going to do them as elective cases. You can see the dense stone-like calcium you can see in the background. And my first job is to do a rotational atherectomy, which I do from the left main to the LAD ostium. I go down into the LAD. But as I go to this next step, over here, I spend a huge amount of time. This is like multiple runs, 3 minutes of rotor time, 190,000, and trying to push this further. When it takes that long, come back and take a picture, because you will see what happened. When you come back, you can see that a neo lumen is formed. Can you see that neo lumen? I represent that with that little yellow shadow in the cartoon. It tells me that any further rotational atherectomy is going to be risky. I could either have my burr stuck or I could rupture this artery with a rotational atherectomy. But the rotational atherectomy has probably done enough. And when you start seeing neolumens like this, you be rest assured that this block will expand. So that's what we did. This is that neolumen, and this prompts me to stop with rota. Please, my advice to most people is when you see this, don't go ahead and push your rotablator burr anymore. My LED, we take a 3.0 NC balloon, go, and basically we do this to identify any undilatable segments so that we can then choose our IVL for the same. But we were able to dilate the LED through and through, except for the ostium with a 3.5. You see that it's not expanded. These subtle unexpanded balloons are a clue that your stents are going to be unexpanded as well. Remember that. NC balloons 3.212 into that ramus, and you can see it's a clear shelf causing an indentation which has expanded at 18 to 20 atmospheres. I've created some room. I take a flex dome and I further expand that over there. So my circumflex was forgiving. It allowed me a balloon dilatation alone. I didn't have to do a rotoblader because it was a hairpin bend. Also remember, in these hairpin bends and calcified lesions, don't try to put your IVUS catheter. It is difficult to go, and when you pull it back, you may lose the tip of the catheter. So imaging is very difficult in these hairpin bend calcified lesions, and therefore you have to rely on only imaging from your IVUS, like here, from the LAD, and coming back, you can see those images coming back and have a look. The distal landing zone is around 2.8 or 3.0 millimeters. The next shows that the LED distally is eccentric. What does it tell me? It tells me that even though this artery can take a 3.0 stent, because of the eccentric plaque, I'm going to undersize my stent. Because if I take a 3.0 stent in this fibrocalcific lesion, I can very easily rupture the normal side. So remember, eccentric lesion, undersize the stent. I come to an interesting image in the center. It shows me that even though the angiography showed that the diagonal branch was involved, my IVUS confidently tells me that I don't have to protect that diagonal branch. And you can see the LED, and you can see the dual figure of 8 lumen, the new lumen formed. The LED lumen is to the side, and the diagonal is to the opposite end. You can see the proximal end is eccentric calcium. We had already known that from our CT. The ostium of the LED is circumferential calcium. So is the distal left main, and the landing zone in the left main is around 4.2, 4.5 millimeters. So here we use the IVL balloon to kind of expand on the unexpanded segment. And here, this is the last, this is the stents placed in the LED. So we put in a long stent just beyond the diagonal, and then the proximal. We put in our circumflex stent foot. It was a culotte. This is the angiographic result, and our IVUS coming back. You can see it's perfect. Our MSAs were perfect. Imaging pre of the left main. These are the important issues. The circumflex ostium is critical. The plaque at the carina, the luminal area, the plaque burden at the circumflex ostium, and the length of lesion at the circumflex ostium. It is going to decide the strategy. The angle is important in deciding the strategy as well. Narrow the angle, less forgiving is the technique for a single stent. Lesion, the blue segments will decide the strategy and the devices that you're going to use to prepare the plaque. Landing zones are important, which are in the pink. Plaque burdens of less than 50% with stable plaques are chosen. Luminal diameters and areas are important. Reference diameters and areas are very important to be able to judge stent sizes. Plainly, it is just understanding these zones which is going to help us in the PCI. Imaging post-PCI, we need to look at the core images, which are in the center, to look at the results and the MSAs, the residual plaque burden and tissue prolapse. At the distal edges, you need to look at residual plaque burdens, dissections, appositions. This helps you optimize the PCA. these are our strategies. Until 2018, we had either do a gentle rotablator or an aggressive rotablator where you upscale. And then the option was you could choose any one of these balloons, but they're all high pressure techniques. And your rotablator was limited to a 1.5 or 2 for most labs. And our practice, 90% is 1.5 and 10% we would upscale. This indicates a huge gap, which means that we have the IVL, orbital atherectomy, and ELCA. We don't have orbital atherectomy or ELCA in our lab, we have IVL. So, and the reason is that when we used the plaque modification single burr technique, we had large number of patients where we were not able to expand in spite of very large stented areas. You can see we never achieved what we set out to achieve. With the aggressive approach of rotablator, where we upsized to either 2 burr from a 1.5, we were able to achieve, but even then we had a large area. We had still 15 to 17% of patients who could not be expanded. Now, this is what gave me some insight from this case. This is a circumflex ostium. We did not prepare this lesion well. We put in a 4.0. This was the angiographic result. And this was flexed home with a stent. 8 months later, ISAR. We then went in with an aggressive burr strategy, 1.520. And this is what we got. Again, a 4.0 stent, a second 4.0 stent. So what was different in these two? When you use these, you get the cross-sectional areas are so not good, 4.5 and 10.2. Not just that, when you look at the stent struts, they're all crowded in one side in these unexpanded calcified lesions, whereas when you prepare them well, they are symmetrical, and this also contributes in the long-term results. Calcium, there are various calcified nodules and calcified distributions. They'll all require and invite a separate technology. We still have a lot to do in this area, and this is a complex module of how we use technology in this space. Could be discussed at length if somebody asks a question, but I'm going to stop here and exit from this and invite comments.
Just a small request. Ziad is literally in a family crisis. So I'm going to let him kind of do this and really appreciate it. And so whatever time he can spare, let him just go on, and then we'll kind of come back for the discussion.
Okay.
Hi, guys. Sorry about that. Yesterday evening, my wife twisted her ankle and is now completely immobile, which means I'm looking after a 4-year-old and a 1.5-year-old, which is much harder than interventional cardiology, I promise. I'm sure many of you remember. So the unsung heroes. So, Curdy, I saw your fantastic cases. Everything you said is really just spot on. You know, understanding the imaging, understanding wire bias, understanding calcium fracture, how to make complex cases simple. I mean, honestly, I could have said it better. So it was fantastic work. So because of my, honestly, because both of my 2 little girls haven't eaten anything, I'm going to crack on. We're going to talk about bifurcations using OCT, and then I'm going to make some pancakes. So we're going to get started.
Guys, can we have, yep, there we go.
Okay, so, you know, unlike Curdy's cases, mine is going to be a little bit more theoretical, at least at this point. You know, I think in the future I can go through a step-by-step OCT case, but to be honest, I want to talk to you a little bit about the limitations of OCT and the limitations in data for bifurcation, as well as to help you kind of understand where the state of the art is. So first of all, bifurcations are common, right? So 15 to 20% of total PCIs involve some bifurcation. PCI in these circumstances is clearly challenging. We've all been in these situations, whether it's doing a provisional and trying to get back across, then we've got subintimal, whether we pre-dilated the side branch, created a section, we don't know what to do with it. So clearly it's more technically difficult, it's time consuming, there's higher resource utilization and cost, there's lower success rates, and there's inferior long-term outcomes. And there's really uncertainty about the best treatment strategy, just like we said. While we've moved towards a provisional approach, I think we need to be a little bit more intelligent than simply saying the provisional approach is the way to go. And I'm going to try to convince you about how some of the current data taken in the context of contemporary PCI might be helpful. So these are strategies based on personal experience, lack of robust randomized data. So first of all, do bifurcations really matter? Well, this is an individual patient meta-analysis of all comers. You can see the numbers are big, right? So somewhere around 8,500 patients. And if you take any bifurcation versus no bifurcation, the target vessel failure rate at 1 year is higher. The hazard ratio is about 1.31, so there's a 30% risk. So it is indeed a legitimate concern. So let's talk about really what is a bifurcation, all right? Now, we're all familiar with this Medina classification, and most classification systems are developed for research. But what we really need to focus on is what I think is true bifurcations, clinically relevant bifurcations. And that is when we have lesions that are in this main branch distally and side branch, main branch and side branch, and then proximal main branch and side branch. So this is what is known as a true bifurcation lesion. So, but this is not really helpful for the procedural planning, is it? So if you see this information, so what, right? If the lesion's proximal or distal, how does it help you? So one of the questions, of course, that's constantly coming up is 1 stent or 2. And as you all know, the European Bifurcation Club has said that a provisional side branch stenting approach is recommended in most cases, and a minority of bifurcation lesions require a 2-stent strategy. And I think we overall would agree with this. Lesions with difficult wiring, a large side branch with extensive disease extending 5 to 10 millimeters may be best approached by 2-stent technologies. But let's remember, we have to first prevent no harm, right? Primum non nocere. Wire both branches, main branch and side branch. This should be irrespective of whether you plan a 2-stent strategy or a 1-stent strategy. As part of the PI of a Lumen 4, I sometimes have the great misfortune of seeing investigators stenting across 2.5 millimeter or larger side branches with no side branch wire protection. And in the context of imaging guided PCI, where we're using larger stents and higher pressure balloon dilation, it is a predictable event that you will end up pinching these branches and causing harm. As a result, the bifurcation results or bifurcation events are worse. Not wiring a side branch greater than 2.5 during main branch PCI is like putting your child in a car without a seatbelt. It's totally unacceptable. It prevents plaque shift, provides a marker for your side branch, and makes the angle favorable and helps rewiring in the side branch. It's just lazy not to do it. So where's the data? So let's take a look overall at probably what I think is a fairly good or contemporary meta-analysis, and even this is quite old. So cardiac mortality, not different, not surprising. Why would a bifurcation affect mortality if regular PCI doesn't? So cardiac mortality is not improved for any lesion-specific PCI. Bifurcation is no different. What about target lesion revascularization? Well, target lesion revascularization, placing a stent into a tight stenosis reduces TLR. And so what you can see, of course, is that this is favoring the more complex strategy. Part of this is reflex, part of this is legit. Because if the patient comes back with any symptoms at all, and we know that 20% of patients come back to the hospital with chest pain after having their PCI, if you have a sitting duck or a low piece of hanging fruit, you'll take it. So that ends up getting a PCI. What about meta-analysis for in-stent re-stenosis? You can see main vessel re-stenosis and side branch re-stenosis also lie on the right side of the line of no effect, although not statistically significant. So if you remove the stenosis, it's harder to get a new stenosis than if you never treat in the first place. Obvious. What about early myocardial infarction? Now, this is an important slide because it's got a very simple message. You have a higher risk of an earlier myocardial infarction, including peri-procedural MI, if you favor a simple strategy. You have a higher risk with a complex strategy. And that's because if you mess with the side branch, you can injure it. And if you don't mess with it, it's really hard to hurt it acutely. So this is a simple message, right? If you leave something alone, you really can't shift plaque in it. You can't end up embolizing lipid from it. You can't really, it's much harder to get a re-stenosis from it. What about overall myocardial infarction? Well, this includes peri-procedural myocardial infarction. So side branch ostium are negatively remodeled muscular lesions. They are less vulnerable. They typically do not accumulate large amounts of lipidic plaque. And if you looked at some of Curdy's IVUS images, we could see that, right? Usually when we come to the ostium, it's a much more muscular part of the artery. What about stent thrombosis? It's hard to get a stent thrombosis without the stent. So if you put 2 stents instead of 1, you double your chance of getting a stent thrombosis. It's really very simple, especially with the amount of metal that is left over in the side branch. So while there's little overall benefit seen in randomized trial with final kissing balloons or second stents, most trials were not all Medina true bifurcations and did not have complex side branch stenosis. So let's look at a more practical approach adopted by this is adapted from the EDC. You do an accurate assessment of your lesion severity, distribution, extent, and presence of concomitant disease. You see a true bifurcation if it's large and the side branch disease is diffuse and extends well beyond the ostium. Elective implantation of 2 stents is suggested. If the side branch has an unfavorable angle for recrossing after main branch stent implantation, elective implantation of 2 stents is recommended. This is an extremely important slide. I probably use this slide for more of my talks than any other slide because it really encompasses the reality of combined imaging and physiology. So let's break it down. This is CCTA-derived fractional myocardial mass in the major coronary arteries. Now let's take a look here. At the left main, the proximal LAD covers 48.8% of the myocardium. The proximal circumflex covers 31% of the myocardium. Now it makes sense why the results of DK crush are the way they are. If you do a 2-stent strategy and you have a huge amount of myocardium to save, you'll save it. So you can now see the benefit. But now if you go ahead and look at the diagonal, which is boxed in red, or an OM, which is boxed in red, you see that doing an LAD diagonal bifurcation has a lot less benefit because the amount of myocardium subtended by that branch is considerably smaller. So when we decide whether we're going to do a large 2-stent bifurcation strategy, we really need to think carefully about the amount of myocardium that is subtended by the branch that we intend to save. So practically speaking, that means the proximal the circumflex, or really the first diagonal. I haven't shown you this data, but actually it turns out the second diagonal covers an extremely small amount of myocardium. And look at the ramus, a tiny amount of myocardium. So when we start doing, trifurcation, culottes and trulots and whatever you want to call them, you have to think about what the value of is putting another stent into that branch. So this is that data I was talking to you about. Look at the difference in anatomical bifurcations in terms of the distribution. In the left main, you can see a large amount of territory covered by the circ, a reasonable amount from the LAD and diag, but the second diag is relatively small. And so taking this information into account helps us determine how to perform bifurcations. And if we look at the primary safety endpoints, what we see is that cardiac death between DK crush and provisional is not different. Target vessel MI, it was higher in the provisional group. Target lesion revascularization was higher in the provisional group. And remember, this DK Crush 5 study showed that there was a significant benefit for patients for a 2-stent strategy because it's all about the amount of myocardium that's subtended. This is a graphical representation of what I showed you before. Look at the prox LAD diagonal. It's a reasonable amount of territory to cover. But look at the mid-LAD second diagonal. The second diagonal almost covers no myocardium. So putting stents in there is going to cause more harm than good. In these situations, I would strongly recommend performing FFR, RFR, IFR, whatever you want to do in order to determine their physiological significance. What happens when you jail a side branch? If you jail a side branch and you use an undersized balloon, 0.7 to 1 ratio, and balloon it, the impact of that is to have a very small risk of a target vessel failure. When we look at that CT data, the multivariable generalized estimated equations, the risk factors for having a positive FFR or positive functional myocardial mass in a side branch is that the side branch is long, i.e. covering a lot of territory, and that it's in the left main, i.e. it's covering a lot of territory. So now when we start to look more detailed at the True bifurcations, so target vessel revascularization in side branches greater than or equal to 2.5 millimeters, it favors a complex strategy. When we look at main vessel restenosis with side branch greater than 2.5, it favors a complex strategy. And then again, if you look at target vessel revascularization and main vessel restenosis together, it again favors a complex strategy. So I need 2 stents. Which technique? You know, there's all these different provisionals, bailout, V, DK crush. It's all like all over the place. So how do we decide? Well, 2 stent bifurcation stenting techniques really fall into bailout techniques and upfront 2 stent strategy techniques. And I think for the vast majority of us, we're using DK crush, culotte, and using T stenting or T and protrusion for bailout strategies. If we look at the predictors of target vessel failure in 2 stent strategies treated with 2 stent in these 951 patients, again, large territories, high amount of myocardium at jeopardy, and diabetes were the predictors. Second generation drug-eluting stents, non-compliant balloons, and final kissing balloons were negative predictors of target vessel failure. So as you all know, I'm running a Lumen 4. We included bifurcation for this reason because it's significantly at risk, and I think that OCT can significantly impact this because it can allow us to determine the morphology of the side branch and the dynamics of that side branch. So what we're doing is including 2 stent bifurcation. Approximately 15% of our total target population is going to be 2 stent bifurcation. As we move on towards OCT, I want to say that a lot of this is expert opinion. We don't have a tremendous amount of data. This is the joint consensus on the use of OCT in coronary bifurcations by the European and Japanese Bifurcation Club. Again, a large patient population. OCT provides unparalleled resolution. OCT 3D reconstruction provides a unique opportunity to study and treat bifurcation lesions, but evidence is lacking. So let's take a look at the available data. So we have a number of retrospective single center registries, and what we find from these is malapposition is lower, malapposition is lower, malapposition is lower, no benefit of bifurcation, PCI versus medical therapy, and this minimal expansion index is better than the minimal stent area. Not exactly data that we're ready to pull out stents and use OCT in every case, is it? Rather, it's really sort of hypothesis generating about what does this malapposition in the side branch do? Does it really matter which wire you really or what strut you cross? And is it worth the effort, time, and contrast to be able to find this information out? This is what's going on. The doctor's Recross study, which is a dedicated bifurcation study, Optimum, a dedicated bifurcation study, and the October study, which I'll talk to you about in a little bit more detail. So practical tips for bifurcations. It's not cheating to predilate to get a high quality image, whether it's in the main branch or the side branch. I regularly perform predilation routinely before OCT in order to get an optimal image quality. Remember, the impact of the balloon on the plaque morphology will not change your clinical strategy because the clinical strategy is really dictated by the degree of calcification and not the amount of lipid per se. Co-registration may be very helpful to minimize geographic miss of both side branch and main branch. When available, use of online 3D reconstruction is recommended to facilitate an understanding of the complex coronary anatomy and device interactions. Unlike with IVUS, 3D assessment of ostial area from OCT pullback of the main vessel is a good substitute for a pullback from the side branch. You've all been in this situation. We've done a bifurcation PCI, we put the IVUS back into the side branch, and on the way back, it gets caught on the struts. And as we pull it back, it gets caught on the struts, we feel that interaction, and now we don't know what to do. Do we go back and kiss again? If we kiss again, do we image again? So using the OCT in the main branch and visualizing the side branch as a useful technique to be able to minimize further imaging in the side branch. I have actually eliminated, after my pre-PCI OCT guided strategy, eliminated routine side branch OCT imaging. So what are things that we can learn in great detail with the imaging resolution of OCT? Let's take here an example, which I think is just a beautiful image. You can see in this bifurcation that there's a clear-cut carina on the 3D reconstruction. When we stent, we crush this carina. You can see the wire is jailed in that branch. And finally, when we perform kissing balloon inflation, we reconstruct this carina. So there is, in fact, a imaging which confirms our biological plausibility of the techniques that we perform. The bifurcation OCT software is really very utilitarian. It's not hard to use. It creates simple reconstructions. One, I think, careful point to remember is this is one of the situations where OCT 54mm pullback is better, right? The reason is in a 54mm pullback, you don't cut frames. You're not skipping the other frame, and as a result, you'll have the appearance of a continuous stent instead of small fragments in between, which make it difficult to determine where your wire has recrossed. This is an important tip that I have been using in clinical practice, to look at the side branch angle and the carina tip angle. When the carina tip angle is less than 50 degrees, and a branching point carina tip length is less than 1.7 millimeters, there are independent predictors of side branch complication after main vessel stent implantation. This is really quick. It's fast to do and easy to understand and helps to determine what your risk is. And to be honest, sometimes how I'll use this information is it will prevent me from actually putting in a longer stent. So if I have a high-grade lesion and I want to cover from normal to normal, and I have to go across a side branch such as this, and I see this type of information, it might actually limit me from needing to do that. Bifurcation stent sizing in the main branch. We use the EL if it's visible, the Lumen if it's not visible, and we perform exactly the same strategy in the side branch. Now, the important things to remember when you're doing a bifurcation are two. Number one, use your OCT ruler to make sure you have enough millimeters to do a pot. It's a bad idea to put a stent across and leave only a few millimeters in proximal to your side branch because we won't be able to see. The second thing, of course, is to make sure that when you do post-dilation, your pot balloon should be sized to proximal to the side branch and distal to the side branch. In our OCT stent sizing algorithm that's used in Illumian 4, we do an EL guided approach in the side branch. If we can see the EL, we round down. If we can't, we round up. And when we look at the impact of stent expansion, we look distal to the bifurcation and proximal to the bifurcation. And the reason we do that is because, of course, this is natural biology. When at the bifurcation point, the vessel splits for a specific purpose, and the amount of flow that goes distal to those branches is dependent upon those branch vessel sizes. This is an example of where we've done an OCT guided PCI. We look at the impact of the expansion distal to the bifurcation, which is marked now by a red dot, and we look proximal to the bifurcation, which helps us to determine whether we have adequate expansion and adequate pot. So bifurcation stent sizing, the operator should aim to cover the bifurcation stenosis segment at least 6 to 8 millimeters from the proximal stent edge to the bifurcation to facilitate pot. Oh, now what about this issue about the cell? Well, honestly, I think this is extremely complicated and there's not good enough data for us to be able to establish which way to go, whether we go through a proximal cell or a distal cell. What we do know is that if we cross a specific cell type on a specific stent type, that we can end up with either more or less metal covering the carina. What the exact impact of that crossing is to clinical outcomes remains to be determined. At the moment, optimal recrossing is a distal recrossing, which promotes a better osteal side branch stent coverage and apposition. Proximal recrossing results in unusual strut deflection, a lower strut coverage of the side branch ostium, and more overhanging metal. Use of OCT is recommended to exclude this accidental abluminal rewiring and to assess the position of the recrossing, and 3D high resolution can be of great utility in this regard. So final kissing balloon inflation is associated with improved anatomical and functional results at the side branch ostium. I'm going to finish off with some data about the October study, which is a specific study looking at side branches. It's randomizing 1,200 patients to OCT guided to standard therapy, a major undertaking in my opinion, because you can imagine what it takes to enroll one of these patients with a primary endpoint of 2-year MACE and 10-year follow-up. Incredible. Bifurcations, these are some of the problems. The ostium of a diagonal after a culotte looks beautiful on the angiogram, looks terrible on the OCT. What about the registry data in terms of major adverse events? We can see distal left main bifurcation, moderate to severe calcification, non-left main bifurcations have specifically worse outcomes, which is how they identified their target population. The treatment goals: full lesion coverage, optimal vessel and stent expansion, and full apposition, and no accidents. Their simple stenting strategy: predilation, check for lesion preparation, sizing, positioning of stent and pot balloon, and stent implantation with first pot and rewiring of the distal stent cell, and final kissing balloon inflation. In their complex strategy, they do a similar strategy: predilation, stent implantation, first pot and rewiring of the mid-stent cell, and then final kissing balloon inflation. So I'm going to leave you guys on that note. Maybe take a few quick questions if there are any, and thank you for your time.
So Ziad, really appreciate doing this talk. You know, I know how it is to have like young kids and a sick wife. I mean, really appreciate it. So if there are any burning questions for him, I mean, maybe a question or two, let's just kind of do it, and then he can be off and do some pancakes for the kids.
I'll send you a picture.
Excellent, Ziad. I think, as usual, excellent talk. And actually, we are just enrolling patients for Lumen 4. We just enrolled the first patient.
Yeah, so, I saw. Thank you. I saw I get all the notes.
Okay. And the interest, I want to ask you, so to differentiate between block shifting versus a Karana shift, to decide whether to intervene the side branch or not after stenting, crossover stenting. Maybe a OCT run into the side branch, will it be more helpful to assess exactly the vessel size? Because when you do a run in the main branch alone, you may not be able to assess the size of the side branch well. What do you feel about it?
So, so I think if we follow the EBC rules or guidelines, right? If we stent across the main branch, the patient has no EKG changes, it's not a significantly large side branch, and there's not a 90% plus stenosis, I think we leave it alone. I mean, I think that's the general EBC approach. I think if you do end up with a 90% stenosis after side branch pinch, you have an issue. My personal preference in those situations is to use a pressure wire.
Yeah,
right? Yeah, and so it just eliminates any ambiguity for me, right? I go in, I know what the flow is like, and I'm done. If it ends up being positive, I'll use a small undersized balloon to dilate it, and then take another picture with an undersized final kissing balloon. You know, I understand the cost implications.
Yeah,
they are very relevant. But if it's a big enough branch for you to worry about, then you have to think about it. Because obviously, if your angiogram shows a 90% stenosis and you image it, it's going to be tight. And you'll be stuck in that situation about knowing whether it's Karana shift or plaque shift. Because at that point, it's just going to look like a dark hole, right? It's just because the stenosis is going to be so tight.
The other thing, let me ask one more question. We very often when we do OCT, we see proximal most strut malapost, few struts malapost, and we are not able to position the balloon exactly if we do a pot. And you know, we are also concerned about injuring the proximal part of the normal vessel. So do you, I mean, even though if it's circumferential malaposition, do you leave it? Because we see it when we frequently do OCT for bifurcations, when you do a pot, still we have that kind of malaposition.
You know, I have to say that I'm not convinced with the data yet, right? And I think the one thing that I spent like 10 or 12 minutes on at the beginning of this talk is, if you mess with the side branch, you can F it up, right? So leaving it alone without compelling evidence to go after it, I think is probably the most favorable approach. And it has to be worth it, right? If the branch is big and the patient has EKG changes or chest pain, you know what? we're all good at this. We know how to rescue it, right? We know how to get in. We'll do the techniques. We'll use a microcatheter. We'll use kissing balloons. We'll do whatever we got to. But the most important slide I showed you was the CT, right? That's the slide you probably haven't seen a lot before, but it's also the most educatively informative. Let's go for the big stuff. If we go for the big stuff, we're more likely to save it. We start messing around with the small branches, we're going to end up with more harm than good.
Great points. Ziad, thank you.
My wife's texting me, so I think that's my cue.
Bye, Tata. Like, see ya.
Hi, guys.
I don't want you to hate me. All right. So, Keith, fantastic talk. I mean, I'm so sorry we didn't have the discussion right after your talk. So, yeah, I had to kind of switch things around a little bit. That was just mind-blowing as always. And, I mean, I think it was a great, really good sequence of talks today with Ashri, you, and finishing it up with Ziad. So I'm sure, I mean, your cases, of course, were mind-blowing. I would love to have Dr. Imad like kind of weigh in on some of those cases. And then we'll kind of go from there. Take a couple of questions. We'll kind of pass it around, and then hopefully I won't keep you guys up for too late.
Well, actually, I mean, we have seen highly challenging cases. He is a master in this, and I think very educational cases. The key in these cases is how to prepare adequately your lesion before stenting. Stenting is the last thing to do. Yeah. You should prepare your lesion carefully. You should study your case carefully. Decide your strategy before starting. This is another key point. So I think all these things were included in the cases we have seen. And congratulations.
Thank you, Imad. Thank you.
Yeah. So one of the questions from Fahim in Singapore, I'm going to have Dr. Singh's just joined us, so I'm going to have him kind of take this question. So in the light of definition 2, should there still be a role of provisional for the circ at all when you're treating left main LAD circ bifurcation disease? Thanks, Dr. Sangatavelu, what's your take on it?
You mean the provisional stenting, the role of provisional stenting?
Correct. Should you still even consider provisional for circ at all, or should we just go with a dedicated, bifurcation strategy when you're dealing with complex left main LAD circ disease?
I think with the increasing use of imaging and physiology, I think we still can consider provisional, I personally feel. And with there's no significant disease in the ostium or the circ, of course, we do provisional. Only with that, do a final kissing. Although, for a provisional, there is no clear data to whether to do a final kissing or not. I would, in a left main situation, I would strongly feel to do a final kissing. To not leave any protruding struts across the branch. We have seen from imaging studies of formation of bridges and all that in the late formation of bridges across the struts. So with that, I think I would definitely consider provisional if the circumflex is not having much disease. There are some IVS data which says that if you have if there is no much of block burden less than 50%, and if the MLA is more than 3.5 square millimeters, you can just do a crossover stenting from F main to LAD.
Let me make another comment on this about provisional and distal left main. I think 2 points should be considered. One, we have a lot of data showing that provisional stenting, when it's feasible in distal left main, is doing much better than 2 stents in terms of less space on late outcome. The problem is when is feasible, how to answer about this. And the answer is should be coming by definition study. That means definition study, the aim of definition study was to define what is simple and what is complex as universal definition. Because if I'll present a case, maybe I'll present a case like very complex bifurcation when it is very simple, and complex is not defined. So definition, the aim of definition, I mean, I was one of the co-authors of the first definition study, and we have major and minor criteria to define what is simple and what's complex. I agree with you that is not simple. The criteria to consider all these criteria every time you are dealing with bifurcation is not simple. So we should go ahead and maybe try to have more simple approach to define the complex and simple. But again, mainly depends on the extension of disease on side branch, whether it is distal left main or non-distal left main bifurcation lesion. If you have short lesion on side branch, I think provisional stenting is always feasible, except in very difficult access, very difficult anatomy, tortuous vessels that you might expect dissection also on side branch. But in the majority of cases, you can expect very good result with provisional stenting when you have short lesion on side branch. So this also valid for distal left main. Definition 2 study, which was published just last month, was dealing with complex bifurcation. All patients included were defined complex by definition criteria. That means having longer than 10 millimeter lesion on side branch, whether it's distal left main or non-distal left main. So this to remember every time, because I have seen some question saying that after definition 2, is there any place for provisional stenting in distal left main? Yes, still. In simple, still there. Provisional stenting is better than 2 stents. This, I think, yeah. I think
no, that was a very, I mean, I think that really kind of answered that, question. So, hey, Kirti, there is one question that has come up from Dr. Saibal. So, do you want to take it? That's about your first case. Can you see that? Yeah.
In the first case.
Yeah, where in the first case, left main to ramus followed by left main to LAD.
Yeah.
So final kissing done where and when did
3 stents? 3 stents.
Yeah. Did not do the Karana not. So the stent, every trifurcation, I mean, when you look at the trifurcation, you got to mentally and imaging wise divide it into a true trifurcation and a pseudo trifurcation. In what I have seen is that most trifurcation left mains are pseudo trifurcations because they have one trifurcation and then another. Because they are so closely following each other, they almost behave for all practical purposes like a trifurcation. I spend a lot of time trying to unravel this, and if I can separate that, then that's what I did in this case. So my first bifurcation was these distal circ and the ramus, and when I do that, then I have to complete it with a bifurcation final kissing balloon and doing a final kissing, which I did not because I had to cut off 5 slides so that I could finish the talk in time. So when I did my first stent and I put in my second stent into the ramus, that is your first bifurcation, and you have to do a final kissing balloon first and then do a pot of the circ ostium and then prepare the left main with a pot for the LAD stent. Now, having solved the first bifurcation, which is the distal circumflex and ramus, now for me, during the final bifurcation, I then just have to come to the proximal bifurcation, which is the ramus and the LAD. So for me, I'm constantly trying to see if I can do them in series, because as a single operator with only one nurse on my right, the last thing I want to do is a separate guiding catheter for the third balloon, or to have 8 French and 3 indeflators handling 3 different balloons, because the more complicated you make your procedure, the more likely that you're going to have a MACE in that procedure. And that's important. The longer you remain in the cath lab, the more likely you're going to cause trouble. Most trials look at results. They know what's going in, they know what's going out. But what we miss in the trial is what happens in the cath lab. And sometimes Many cath labs, many results and studies don't report the closure of a side branch sometimes, which caused a hemodynamic consequence and a resuscitation by the fluids or inotropes for a short time. All these things, in my opinion, must add to an adverse long-term outcome in some way or the other, because then the operator rushes to complete the procedure. So I may not have the answer to every right thing we do, but I think if we systematically do our steps one step at a time and follow the basic rules, then I think we're going to be okay by and large.
That was great. So guys, like I want to be respectful of time. I know for some from the East Asia, it's been super late. So why don't we, any concluding remarks from, I mean, we kind of just go, Dr. Imad, do you want to talk about anything and just kind of just give your take-home messages for the audience, please?
Well, I will start with the very essential point for me. When you are dealing with bifurcation, I am not now referring to distal left main by bifurcation in general. The first thing to do is to determine whether is side branch relevant, clinically relevant for the patient or not. Because this is the first step, should be for every non-distal left main bifurcation. When distal left main bifurcation, of course, is not side branch, we have two main vessels, then of course side branch is almost irrelevant. This is one. Second, if it is relevant, then I think the second step should be, what is my study should be accordingly to the complexity of bifurcation. That means if you have complex bifurcation defined by some criteria, and I think what I am following today is mainly extension of disease on side branch and anatomy, difficult anatomy for side branch. That means difficult access or tortuosity on side branch with even less extensive disease that might, if you are inflating anything there, you will have dissection. Then I will plan for two stent strategy. Otherwise, I'll go for, as default strategy, provisional stenting. And then if you have some compromise, that means that you shift to two stent technique, then as have been said today, you should be almost every time sure that you will have your exit strategy. That means to go for second a second stent strategy from provisional. When you have complex, then go for complex as default strategy. That means two stents technique. For me, there is no big differences, at least coming from studies, between any two stent strategy, whether it is DK crash or DK cool out, or let me say any modified T stenting like TAP or reverse TAP. The main thing is to be confident with your strategy. That means you know how to do it optimally, and again, go step by step every time. That means don't hurry up. Take your time, do everything as best as you can do, and particularly important in many patients, lesion preparation, as have been shown in many cases. Because again, stent is the last thing to do before prepare your patient to have the optimal result with your step. So step by step. If you have small branches, that means not clinically relevant branches, just keep it open. Don't worry about any other thing. Keep it open, and that's it.
Great. Look, Keith, you want to say something? Unmute. You're muted.
Just two very brief things. One is when we look at the data of the two stents versus the single stent, we have divergence up to the year, up to the 12 months. And if we take off and eliminate that data, those two run parallel after that. So whether you use two stents or you use a single stent, these patients do quite well after the first year. It says that we have to start believing that we probably are just not doing things correctly to a large extent. And we need to redefine our definitions of success in the left main, and they cannot be based on angiography. They have to be based on an imaging endpoint period. So gone are those days when you're going to just have an angiographic result and say, okay, that was perfect. I think that's the first point that's a very important thing. The second thing I'm going to say is that I hope that we get the DCA again. Because if we could do an image-guided DCA in one of the branches and selectively remove eccentric plaque, which is possible because we used to do it 20 years ago, I did it, and we could do it very well and effectively then without imaging, I think we'd be able to do it with a loaded imaging catheter inbuilt. I think that would be the way, that would be a game changer, because then you could do a DCA followed by drug-eluting balloon in one branch and stent the other. Left main would be child's play, except for DCA is not child's play, really. So we need to relearn that technique, and I hope it comes back.
Well, that will make it more difficult.
Dr. Deepak, do you want to talk on any comments about
just wanted to, no, it was extremely good. Just wanted to ask Kirti. He's been the single operator inside the cath lab doing so many things, and even we all do IOS, but then many times for presentation's sake we have to go back, rework things. But do you really go through all this information while doing stenting, or do you have somebody, some expert on IOS to look into all these issues and get you the information regarding these?
Arun has been in my cath lab. What do you think, Arun?
He does this meticulously. I mean, the thing that I was really appreciating, like even when I was watching his talk, was, literally, like, I mean, I don't know if he does a PowerPoint, but he definitely does it on paper. He actually has a beautiful diagram that he draws, like kind of plans out the whole thing, like, the meticulousness, like, I mean, it's almost like, when I go into CTOs, it's like, you have to have a plan. You're going to say, all right, this is what I'm going to do. He does that for every complex case of his. And it's, I mean, so
I think Dr. Kirti is a master. And if you know how he started off, he was in EP, electrophysiology. Before he branched off into intervention. I still read your CV and everything. It's just amazing, Dr. Kirti. Fantastic cases.
They kicked me out of EP because I wasn't, I mean, you really need to have a much higher IQ in EP than you have for interventional cardiology. But yes, the roadmap is important. The drawing board is important. It's not important that you have it in your brain. As an operator, you can have many plans in your brain. What is important is for you to have your scrub nurse and for me to have my technicians, one who's on the IVUS or OCT, and one who's on the table. The four of us have to be on the same page. And also my runner nurse who's going to get material. Because what I do is I draw it down on a whiteboard and I say step number 1, step number 2, step number 3. And then I draw circles of which images my technician saves and shows me. And you got to come to my cath lab. And that is exactly what we do. And initially it took a lot of time, but as we got well oiled, I think I must say that I don't have a picture of my technicians who are superb, and they now understand imaging amazing. And I tell you, there are often times then they say, sir, I think you missed something, and they'll show me an image and I have made a blunder and they've corrected me. So I think it's a whole team, Deepak. And without a team, I can stand here just taking credit for all this till the cows come home, but my team actually makes me look good.
Absolutely. Absolutely. I totally agree with you. I mean, it is teamwork.
Yeah.
It is not individual work.
It's not individual, really.
Absolutely.
Dr. Atul, and please go ahead. You got to unmute yourself, Dr. Abhyankar.
Atul and I went to college together. We shared rooms. Right? Yeah, at 12 years, we shared the same room. So if you need any dirt on him, I'm the man to come to.
Vice versa.
No, he's just an amazing, the most brilliant guy I know, really. Yeah.
So just 2 points which are not really the medical or cardiology points, but what Kirti was saying is very important. In fact, I have written an article and I hope it gets accepted about how interventional cardiology is very similar to aviation in terms of filing a flight path plan, in terms of putting a NOTAM data, in terms of talking to your co-pilot, in terms of deciding if you are going to abort takeoff, what to do. So I've written an article to compare what the pilots do. Even after having flown 10,000 hours, they do the same thing again and again.
Yes.
They don't just say, okay, I've been flying for 20 years. This is going to be a cakewalk. It's an everyday situation. The second point I want to mention is that I have seen, and this is probably something for the junior cardiologist, is that when you see something unusual and something exciting, don't jump into it thinking this is my day to catch up with Kirti. So the planning that needs to go into trifurcations and double bifurcations and things like that is extremely essential. So don't start a case unless you have plan A, B, C, everything properly worked out. Every essential tool that you're going to need should be available to you. And you shouldn't sort of realize halfway through. That is what I call Abhimanyu. If people from outside India may not sort of know, but so that's what happens like Abhimanyu is that you go into the Chakravyuh and then you don't know how to come out. So I think that's a very important thing. What Kirti showed was the planning.
Great. Dr. Ashri, and do you want to, any concluding remarks? Great talk again. Really appreciate you guys staying back so late. You and Raj especially. Thanks, guys.
Thank you, Arun. I think it was a great session, and I think I learned a lot from the security and the rest. And
Dude, you muted yourself.
my wife is next to me. She's ironing clothes.
You gotta go to bed.
No.
Thanks, man.
See the wife, you automatically mute.
I know.
Well, we're all muted in front of our wives, isn't it?
Exactly.
Yeah.
No, Raj.
I know, great presentations, great cases. I think very good discussion as well. Just to reinforce what the others have said, I think there are some trainees probably in the audience as well. I think with definition 2 trial, I think we now know that with complex cases, it is safe to do by 2 stent PCI, especially DK crush, if it is a complex case. So I think provisional is still the default option in most of our cases, and that's what we should try and do. But what it means, we should not be afraid of doing complex cases by a 2 stent strategy, but we should do it really well. So when I sort of talk about bifurcation and teaching fellows, tell them do provisional every possible chance. But if you have to do 2 stents, do it really well.
Right.
Do all the steps right. Do your pots, do your kissing balloons, and don't make any mistakes with that. So we need to practice, be really good at it. When the time comes, do it well.
Absolutely.
Fantastic. And Dr. Thanks, please, we have so
I
many
missed
experts here.
Kirti's excellent cases, but I would like to just say the importance of imaging. I think the Light Lab study has pointed out that even with experienced operators, there is a difference when you do imaging.
Yeah.
So some people tell that I was eyes, so I can see by angiography, but I can tell you we can miss a lot of malappositions and under expansion at the end without imaging. So I think the message in all these complex PCIs, particularly left main bifurcations, you have to image. And I imagine, I know Kirti also does the same. All cases, image before and after. That would be my message.
There are no IVUS eyes, I believe.
Yeah,
there are no IVUS eyes. They do not. That's an oxymoron of a statement. And even if there are, they need reinforcement time and again.
I think also another point is training in imaging is very important. I mean, it is enough. It's not enough to perform. How to perform it and how to interpret it.
That's right.
It's absolutely important. So I think every cath lab should have some expertise in intravascular imaging, because it's not. It is not enough just to say I will IVUS that.
So mere imaging does nothing. It has to be an effective, actionable imaging, which is pointed, directional,
Absolutely.
and safety
Absolutely.
met. And, you know, more than just going into the case and planning it, every case you do, spend 2-3 hours after the case and look at what you did, because that's where you will find out what you did wrong. Because not every time you will find out the mistakes as you are performing the case.
Sure.
It is an afterthought.
Sure.
And archiving, a lot of the cases I've learned by archiving. So if you do a case today, you think, oh, you did a great job, and this patient comes back a year back. Now you go back and look at what you did a year ago, and you said, oh my God, I missed this. And I think that's how imaging teaches us, not in that case on that day, but by going back to it in hindsight to see how to explain something that went wrong a year down the track. I think that's important. And that's what I do with most of, we make a library of every case after it has happened.
Absolutely.
Guys, I would
Awesome.
love to
Thank
keep
you, Arun.
going on all night, and thank you so much, all of you. Thanks for staying up so late, especially the East Asian guys. Really appreciate all of your times. This recording hopefully should be on live again. Let me draw this to a close, and then we will resume for the discussions later, I guess. Thank you,
Nice
guys.
seeing you, Sengatoo.
Thank you.
Goodbye. Goodbye, everybody.
Hey, Mad.
Bye.
Yeah,
Stay
Atul.
safe. Bye.
And Arun.
Bye.
Right.
Okay.
Rajinikanth, bye.
Nice seeing you. I was going to say. Nice to see you.
See you guys.
Bye-bye.
Yes.